I now invite Dr. Ramamurthy for his presentation on phacoemulsification in white cataract.
Thank you. I'd like to thank Dr. Titial for his this kind invitation to be part of this course. All of us have handled these situations, and we do realize that the basic problem is getting a good rhexis in these cases. And whenever the intralenticular pressure is more than the intracameral pressure, there's a tendency for a rhexis runoff. It's a fairly old video of mine, but nicely represents the principle. So I'm using high molecular weight viscoelastic and then aspirating the lenticular material. Sometimes when it's flocculant, multiple aspirations are necessary, and everything seems to be under control. The rhexis is proceeding as usual, but it's taking its own time. And all the time the idea is to keep the anterior capsule flat like this and not become a hill like this. And as you can see over here, there is escape of viscoelastic. I should have stopped and filled in viscoelastic at this point of time. Instead, I just go ahead with the Utrata forceps, and immediately I have a rhexis runoff. So as far as this basic principle, which we know for decades, but sometimes we forget to employ that, that's when causes pain. And as far as you're keeping the intralenticular pressure less than the intracameral pressure, then the surgery proceeds in a more methodical, smooth manner. Now coming to some other videos, all of them are fast forwarded, so please bear with me for the videos being slightly jumpy. And this is, as you can see, another white flocculant cataract. And it's always a good idea to stain these capsules, needless to say. I'm going with a 26 gauge needle, aspirating a little bit of cortex. And the idea is to have a small controlled rhexis in these situations and subsequently enlarge them. And I'm using high molecular weight viscoelastic, and that's also injected in front of the intact capsule. You should make sure that it's not going into the capsular bag. Aspirating the lens material also as we go along. And this is a slightly smaller than the usual 5.5, 5.6 millimeter rhexis that I like to. The rest of the cataract surgery is fairly routine with a brittle nucleus, and that's a multifocal lens, a trifocal lens that has been implanted. To get the best out of this, you want the rhexis to be enlarged. That's exactly what we are doing. A small nick in the capsular rhexis margin, and then subsequently in a controlled manner, you can enlarge the rhexis. Using the lens itself as a template, you can go ahead and round it off. Initially it is done with the right hand, then subsequently in the left hand, and then you get a optimal rhexis size so that there is no runoff, but at the same time there's a good coverage and good exposure of the diffractive rings of the trifocal lens. Here is a situation, another intumescent white cataract, and you can see that we begin in a similar manner. And what I'm doing in this case is to create a fairly small rhexis, and then subsequently we have to remember that the flocculant lens material, cortical material, is not only in front of the lens but also behind the lens. So go ahead and aspirate, and as well as give a slight wash, dip down the nucleus, and so that the cortical matter essentially flows out. And once you have done this, then the intralenticular pressures come down quite significantly. You can go ahead and do the nucleus emulsification, but obviously it's a challenge with a small rhexis like that, unlike a slightly larger rhexis that you saw in the earlier case. So I go ahead and enlarge the rhexis, and then subsequently go ahead with the phaco chopping and removal of the nucleus. Usually these are brittle cataracts, though there could be hard cataracts. So chopping itself is not really a challenge, but you can chop them into multiple pieces in a very methodical manner, and all this happens within the capsular bag, and subsequently remove them one by one using adequate amount of viscoelastic and implant the intraocular lens of your choice. This is a situation often talked about, an Argentinian flag sign. Even before I have the time to react, I just was trying to make it curvilinear, but then you have a rexis runoff. Sometimes it's a better to have a runoff on either side rather than a weak rexis runoff on one aspect alone. In this case, I decided to go ahead and do a stop and chop, and using it's running at twice the speed, but otherwise I'm using slow parameters. The entire surgery is done in a more controlled manner. I rotate it through 90 degrees and not along the axis of the rexis runoff, but in the 90 degrees axis. I split the nucleus into two, and then each of the heminucleus is brought into the anterior chamber. With my phaco probe directed posteriorly, I go ahead and chop the nucleus, and it's not continuous application of phaco power. As you can see, the CDE itself is just about 10, and then subsequently I introduce the intraocular lens, which is planned to go in. Here you have the significant flaps which is created, which is covering up the optics of the lens. Obviously, those have to be opened up. This could have been done initially also, but I always like to have the template, the intraocular lens in place, and then subsequently enlarge the rexis. That's two nicks being made. That's in the on the two flaps. This is with the right hand, the enlargement of the rexis, and then subsequently with the left hand, I go ahead and I enlarge the rexis. And then you can see that it's not an ideal situation, but unavoidably I had a Argentinian flag sign. But you can see the intraocular lens, which is ensconced in the capsular bag with the runoff on either side. And in a pediatric cataract with a total cataract, it's always a good idea to stain the capsules in pediatric cataract because it reduces the elasticity. In these situations, once you get the rexis right, most of the surgery is over, unless you have to do a posterior capsular rexis. And as you can see over here, I'm grasping and re-grasping. Here I'm doing it with a Utrata forceps. At that point of time, I did not have a micro-rexis forceps. It's important that it goes in a very methodical manner, and the rexis size that you aim at is around 5.5 millimeters, because there is a greater tendency for phimosis in these pediatric cataracts. Once that's done, the rest of the surgery is fairly routine. This video is just to show the brand little maneuver, and this is the initial part is fairly routine, and there is a turgid cataract, and the intralenticular pressure was not very high, so I proceeded to go ahead and go ahead with my rexis, but then removed a little bit of lenticular material. Please look at this leading edge of the rexis. This is where it will tend to run off here. And once it starts directing towards the fornices, that's when you know that you are in trouble and you need to do something to get hold of the rexis. And here, you do not pull it in this direction, but you pull it back in this direction, essentially in the direction in which the rexis came. And that's exactly what I'm doing. Getting hold of the rexis, then pulling back along the direction and pulling it also inwards. And once you get it controlled, then you can bring the rexis back and continue with it. Of course, taking out the lenticular material. You can see the runoff here. If I had continued with the same manner, it would have gone on to the periphery. Reason I stopped here and then pulled it back in this direction, I could gain control and then complete the rexis in the way I wanted. And you can see a situation like this where there is a tendency to run off. So I go ahead with this is a more recent video. I go ahead with the micro rexis forceps and round it off. Maybe in this case, I should have stopped there and started with the phacoemulsification, because in these total cataracts, hydrodissection is not necessary. So actually, at this point of time, I don't have a rexis runoff. The moment I even do a little bit of hydrodissection, immediately I land up with a problem like this. Maybe this is a worse situation than an Argentinian flag sign, because the area of weakness is all towards 1 clock hour, and there is a greater tendency for these rexis runoff to occur in this situation. So I go ahead and using moderate parameters, low intraocular pressure, and the chopping itself is done in a direction which is not along the direction of the rexis runoff. And as you can see, and once I chopped initially, I bring the heminucleus into the anterior chamber, do as little maneuvers as possible within the capsular bag, but do all the rest of the chopping in the anterior chamber. Push the nuclei fragments back into the capsular bag and then go ahead with the the fragment removal. Again, it's not, of course it happens in the anterior chamber, as deep down maybe at the level of the iris plane, and then subsequently using adequate amount of viscoelastic, but it's doable, and then subsequently the intraocular lens, which was initially planned, does go in. So whenever there is a rhexis runoff, you have to exercise adequate care to ensure that there is not a wrap around, it doesn't extend onto the posterior capsule. Other end of the spectrum, it's not really a it's a Morgagnian cataract, not a flocculant material. As soon as I make an initial nick, much of the milky white matter flows out. But these are aged patients. The capsular bag itself is quite loose and has a tendency to trample it. And it's sometimes this kind of a nucleus just spins around. So in these situations, of late, what I've started doing is to go ahead and bring it into the anterior chamber. This patient was for a hydrophobic acrylic multifocal lens. I implant the lens. Of course, you have to be cognizant of the fact that endothelial damage can occur when you have split the nucleus, but it's really not a hard nucleus, it's a brittle nucleus, and it splits easily. Adequate amounts of viscoelastic being used, with the intraocular lens itself acting as a protection as far as the posterior capsule is concerned. One of the greatest applications of laser cataract surgery is the ability to do a controlled rhexis in these intumescent cataract. The moment I have done that, and when I stain, you can see the capsule is lying there loose, and that almost takes care of 50% of the surgery. And when I go in with a phaco probe, I just close it. But it's not always the case that you get a free capsule like that. Here is just, I'll take a minute. Here is a situation where you can see that I'm using a LRCS platform, but I do not even realize it till now, but only when I stain the capsule I realize the initial gush of fluid itself has caused rhexis to run off. And obviously this again is a situation where the nucleus extraction has to be done in a very controlled manner. So just because you have a LRCS platform doesn't mean that you are going to get a intact rhexis in each and every situation. And last of my videos, here you have a extremely fibrous capsule over here, and in spite of using LRCS platform, nothing has happened to the capsule in this area of fibrosis. Here, if I pull on it with a capsular rhexis forceps, there will be a tendency for the rhexis to run off. So essentially what I do is but I have an excellent template that has been created with the LRCS, and I create a rhexis which is almost 5.5 millimeters, but at the same time this addition is something which neither my capsulotomy needle nor the laser could do anything about. So since it's approachable through my primary incision itself, I go in with a micro rhexis scissors and cut the fibrotic patch over there. Depending upon where exactly is located, you can use the side port or the main port, use a micro rhexis forceps and cut those area of dense addition so as